Thank you. Next we have Dr. Stephen Warwick from the University of Texas, who will be talking about restarting anticoagulation after stroke.
Thank you very much. And continuing with this theme, I'll be discussing the optimal timing for when to start or restart anticoagulation after a stroke, whether that is ischemic stroke or intracranial hemorrhage. And the main theme organizing this presentation is going to be the need for clinical trials to answer these questions, especially in the current era of the newer or direct oral anticoagulants, since what data we have is largely based on heparins and warfarin. So I'll also talk about atrial fibrillation, pharmacologic treatment of atrial fibrillation, although there are many indications for anticoagulation. The most common one, the one most relevant to stroke, is atrial fibrillation. So the questions then are, for acute ischemic stroke, it's not so much whether, but rather when to anticoagulate, and what are the indications for delaying, and which risk assessments are necessary to inform that delay. For anticoagulation-induced ICH in people that have atrial fibrillation, one could take the mechanical approach, as Dr. Saver discussed, but often the decision is to restart some antithrombotic, whether an oral anticoagulant or antiplatelet, or even not is an option. And if restarting, then when. And so, of course, this is the balancing of the risk of recurrent embolic event versus a serious hemorrhagic transformation. Estimates of the early risk of recurrent ischemic stroke are about a 0.5 to 1.3% per day for the first 2 weeks. The risk of hemorrhagic transformation seen on imaging during this period is about 9%. Practice patterns today have largely been based on, and clinical practice guidelines, largely based on clinical convention, which probably dates back decades to when anticoagulation was first used. Small samples, retrospective analyses, observational cohorts, and of course, as I said, most of these data sources were based on anticoagulation with heparins or vitamin K antagonists. The next couple of slides, I'm going to talk about two more recent papers which have informed the question of timing. This one study by Abdul Rahim is a retrospective analysis of data from the VISTA Clinical Trials Archive. These are patients taken from neuroprotective trials, so they generally were not exposed to thrombolytics or thrombectomy, who had atrial fibrillation and received an antithrombotic, anticoagulant, or antiplatelet. The sample size was 1,644. The outcomes by day 90 is that there were significantly fewer thrombotic events, about 10%, with no excess risk of symptomatic ICH. The median time to initiate therapy, whether it was antiplatelets, oral anticoagulants, or both, was 2 days in this trial. And the trial concluded, it wasn't a trial, excuse me, this retrospective analysis concluded that oral anticoagulation as early as 2 to 3 days after the event may be safe. This paper described a prospective observational cohort of ischemic stroke patients with atrial fibrillation. Treatment was chosen by the individual practitioner and was into one of three categories: oral anticoagulation alone, low molecular heparin alone, or a bridging therapy. There were approximately 1,000 patients. In total, 128 events. Some of those were systemic hemorrhages, but in that sample, 3.6% had symptomatic ICH, 7.6% had a recurrent ischemic stroke. Those at higher risk for events, interestingly, both higher risk for either hemorrhage or a recurrent ischemic stroke, were those with high CHADS-VASc scores, high NI stroke scale, large lesion as defined by imaging, or the type of anticoagulation, which I'll talk about in a moment. The study concluded that the best time for initiating treatment for secondary stroke prevention was between 4 and 14 days from stroke onset. Earlier seemed to be associated with a tendency for increased risk of hemorrhagic events. Patients treated with oral anticoagulants alone fared better than those with low molecular weight heparin or bridging. There was a small subset, 12% of the sample, who received DOACs, and interestingly, their event rate, both for secondary ischemic stroke and ICH, were lower than the total sample. So what's the state of the current guidelines? And you'll find that every geographical region has its different guidelines and different specifics of what they recommend. The last version of the American Heart Association guidelines that speak to this were from 2014, and recommending that it is reasonable to start our oral anticoagulation within 14 days after onset, and that for patients at higher risk, defined by large infarct, hemorrhagic transformation already present on imaging, uncontrolled hypertension, or other bleeding tendency, it was reasonable to delay beyond 14 days. Europeans came up with a so-called 1-3-6-12 rule, following the established concepts, but somewhat arbitrarily deciding that TIA on day 1, on day 3, if it's less than an NIH score of less than 8, NIH score of 8 to 15, day 6, over 15, more than day 12. And a survey suggests a similar degree of both equipoise, but also a tendency to find those cut points, although with less precision than the 1-3-6-12 rule. So now we're in the era of the direct oral anticoagulants, and really, at least in the U.S., the factor Xa inhibitors really have been dominating the market. And so most of the data we have to base things on are based on the vitamin K antagonists, with a risk profile about half that, risk incidence, half that for ICH. It really does change the thinking and of the optimal timing. One study that informs this was a pooled analysis from prospective cohort studies. So this is the individual, at an individual patient level, looking at about 2,000 patients who either got vitamin K antagonists or the DOACs, finding overall reduction in composite endpoint events of ischemic stroke, ICH, or mortality out at 90 days, lower with the DOACs. This was really driven by the reduction in symptomatic ICH. In that particular analysis, the median time to initiate was 5 days. There was no interaction of early, meaning less than 7 days, versus later, so it doesn't really inform us about timing, and that there were no conclusions, therefore, on the optimal timing to initiate. Other surveys of what practitioners would feel would be the acceptable range of times to randomize someone to prospective trial were highly variable. So you can see there's a great degree of equipoise, even for what might be in clinical trials. So there, what lists here in this table 4 active clinical trials looking in a prospective basis of the optimal timing for the DOACs. The first 3 are really just looking at early and late. The studies are looking at 30 or 90-day outcomes, generally composite outcomes, as previously described. The 4th study, this is one we've initiated in the Lone Star Stroke Network in Texas, attempts to make a finer distinction about optimal timing by doing a dose or time adaptive randomization with 4-time cohorts, 3, 6, 10, 14. All of these studies are including patients with hemorrhagic transformation. So the START study that I just mentioned excludes the TIAs and mild strokes to try to focus on those where there's more uncertainty. Well, what about reinitiating DOAC therapy after a anticoagulant-induced hemorrhage? Here's a most recent version of the American Heart Association stroke guidelines that are even less precise than those for ischemic stroke. The recommendation is if it's a lobar ICH to avoid future oral anticoagulation. The optimal timing under paragraph 6 says to wait at least 4 weeks in patients without mechanical heart valves or VADs, presumably, and that initiating aspirin monotherapy might be started. And they were agnostic with the usefulness of the DOACs at that time. Well, here's another survey that was published specifically on this question of when to reinitiate. Now remember, the guideline says if they're lobar hemorrhage, which is the lower part of this table, never restart. Well, in fact, most practitioners would restart at some time. Note also the difference between the vascular neurologists, thrombosis specialists, and neurosurgeons in terms of their preference about when to restart, with the neurosurgeons being quite a bit more aggressive in those timelines. So we don't know. This is equipoise in action. So when to reinitiate? Well, there are many retrospective studies. Even in the highest rebleed risk groups, like lobar hemorrhage with multiple microbleeds, it does look like from those retrospective studies that the risk-benefit ratio appears to favor anticoagulation restarting, particularly in patients with AFib. But when? Well, there are a number of trials. I'm going to point out the second one, ASPIRE, which is going on in the US. It's a StrokeNet study. And these 6 trials are really looking at the question of whether to restart or what to restart with oral anticoagulants with either the class of NOACs or specifically apixaban, Eliquis, versus aspirin versus nothing. And these are all ongoing trials which should inform our practice quite a bit. None of these, however, look at the optimal timing. My colleague T.J. Milling at UT Austin Dell Medical School was funded by NHLBI to design such a trial to look at timing, and currently the study's undergoing review for a funding decision. But took the same concept that we used with the START trial for restarting in ischemic stroke, doing a multi-center, it's designed as a multi-center, 50 centers, pragmatic time as the dose. So it's a dose-adaptive randomization trial. And one of the advantages of this type of a Bayesian approach is that it can narrow in on the most effective time cohort and therefore expose more people to a more favorable, less people to a less favorable dose. Randomizing to 1, 2, or 4 weeks is the current design. So in summary, the optimal timing to start oral anticoagulation after stroke is unknown, especially for the DOACs where there's relatively little data. Guidelines and practice patterns are based on clinical principles, but there's really insufficient clinical trial data. Arbitrary time cuts are used, and the data is dominated by data on warfarin. Therefore, there's wide clinical variability in practice patterns and preferences, and so the randomized clinical trials testing different time thresholds and risk stratifications for time thresholds are very much needed and currently underway. Thank you.